The Jerry Powell podcast is brought to you by Archstone Foundation, preparing society and meeting the needs of an aging population. And now, here are your hosts.
Welcome to the Jerry Powell podcast. This is Eric Quidera.
This is Alex Smith.
And Alex, who do we have with us today?
Today, we're welcoming back to the podcast Andrew Cohen, who's assistant professor of geriatrics at Yale and was on one of our earlier episodes. Welcome back to the Jerry Powell podcast, Andrew.
It's a pleasure to be back.
And who else? I see somebody else.
Yes, we're welcoming back to our podcast Liz Dzeng, who is assistant professor of hospital medicine at UCSF. Welcome back to the Jerry Powell podcast, Liz.
Thank you. It's great to be here.
So we're going to be starting off this discussion on guardianship and end-of-life care. Does it change anything if people have guardians? I think I have a guess, but I may be wrong. But before we go into that topic, we always have a song request. Andrew, do you have a song request for Alex?
Yes, I do. Liz and I put our heads together about this, and we settled on Better Things. So it's originally by the Kinks. But there have been a couple of covers, including one by Dar Williams, that we both really liked.
And I like that cover too, but I cannot emulate Dar Williams, so I'm going to do the Pearl Jam-ish version without the Pearl Jam backing band. But tell us why you chose Better Things. I mean, things are going great now, right? Why?
Yeah, we were looking ahead towards what's going to be a really difficult winter and thinking about 2021 and about how things are going to be better sometime next year.
Mm-hmm. Great.
Here's wishing you the bluest sky and hoping something better comes tomorrow. Hoping all the verses rhyme and the very best of choruses too. Follow all the doubt and sadness. I know better things are on their way. It's really good to see you rocking out and having fun, living like you just begun. Accept your life and what it brings. I hope tomorrow you'll find better things. I hope tomorrow you'll find better things.
Awesome. Thank you, Alex.
It's a fun song. Thanks.
Andrew, I'm going to start off with you. So how did you get interested in the topic of guardianship and, whether or not that has anything to do with high-intensity end-of-life treatment?
Yeah, so there were really two different reasons. One of them is that when I started doing my geriatrics fellowship, I realized I was seeing people with guardians or people who needed guardians fairly often, and was for the first time filling out petitions to the probate court and thinking about this system pretty often. And in the hospital had a few experiences, frankly, negative experiences with guardians where I couldn't reach them, or I could reach them, but they didn't make the decision that I thought was clinically appropriate. So I was interested in this phenomenon and found out pretty quickly that it hadn't been studied empirically for reasons I can get into.
Mm-hmm.
The second reason is that I'm interested more broadly in surrogate decision-making and this idea that we intuitively expect a family member to be available and to know how to be a good surrogate decision maker if someone needs one. Mm-hmm. And guardianship was a kind of an interesting model for thinking about surrogate decision making, since in many cases, guardians don't know the person before they have to start making decisions for them. So it can be difficult or impossible for them to try to imagine what the person wanted. And also because, unlike family members, guardians, at least in some states, are having laws that direct them to use a specific standard. So the decision-making process for guardians is both kind of more explicit and in a certain way less complicated because they didn't know the person ahead of time. So trying to imagine what they wanted is usually not possible.
Yeah, and can we just backing up for a sec? What is a guardian? just so we all start on the same page.
So a guardian is a person who is appointed by the court to make decisions for another person who has a diminished ability to make those decisions themselves. Mm-hmm. And in some cases, the scope of decisions the person is having problems with is really confined to financial decisions. And so you can have a guardian appointed just to make financial decisions for you. But in some cases, it's necessary for a guardian to be appointed to make medical and other personal decisions for you, including decisions about medical treatment and decisions about where you live.
That's a critically important distinction, the sort of financial guardian as well as the healthcare decision-making guardian. And that role may be split. It may be combined. It may be that they have a guardian for one, but not the other. Is that correct?
That's right. It can be the same person. It can be different people. And it can also, to make things more complicated, change over time because capacity can change over time. So at various points in your life, you could need one or both of these types of assistance.
And can it be that you have like a family member could be a guardian, or it could be a stranger, the so-called stranger guardian? For example, like a professional lawyer guardian.
That is correct. We think that most of the time it's actually a family member. Probably about 80% of the time it's a family member, and 20% of the time it's a stranger. And it depends on where you live, what type of professional role that person has. Where I work, in Connecticut, it's almost always a lawyer. Those of you in California can tell me if that's true there as well, but it doesn't have to be a lawyer.
Similar in our experience. I don't know about you, Liz, or you, Eric.
I don't feel like I often see lawyers here. I mean, obviously, they're coin appointed, and the ones that we see are usually professional conservators. And when we talk about conservatorship and guardianship, same thing?
For the purposes of the Jerry Powell podcast, same thing.
Okay.
California and Connecticut, to my knowledge, are two of the only states that use the term conservator, or we say conservator in Connecticut. But in most places, it's a guardian.
You say conservator?
We say conservator.
Really?
Tomato.
Palliative.
Right.
Centimeter.
Okay. So in my own personal experience with guardians, when I see somebody has a conservator or guardian in the ICU, I go into a fib or a flutter. My heart starts racing because I know this is going to get a lot more complicated. Going to depend on what county that person lives as far as what kind of I expect how complicated it's going to be. They may feel like they're restricted on what they can do around code status changes. And it just feels harder. Is that kind of your experiences too, Liz and Andrew?
Yeah, I think that in my experience as a hospitalist, when you asked what are the conservators usually like, I was thinking back on my own experiences, and actually what I could remember were the experiences of trying to get a conservator and how it takes months. And then the patient is stuck in the hospital for months while we're trying to figure out what's on. So there's also the legal process of trying to establish one that can be quite challenging.
Yeah, that's been my experience too, that a certain feeling of dread can settle upon the day when there's a sick patient with a guardian where the complicated issues haven't been talked about yet.
And that's why I thought your JAGS article was really interesting. So we'll have a link to your JAGS article that was published, I think about a month ago or a month or two ago. Guardianship and end-of-life care for veterans of dementia. What question were you trying to answer here?
We were trying to find out whether the clinical experience that patients who are represented by a guardian have different types of end-of-life care than other patients, whether that was true. And let me explain. So my experience, and I think a lot of clinicians' experience, has been not only that people who are represented by a guardian present challenges for clinicians, but that sometimes the default treatment pathway for those patients is just to do everything, to provide maximal care up until the very end of life, because the alternative is so challenging. So we wanted to know whether it was really true that patients represented by guardians got higher intensity care than other patients.
Yeah, I mean, if I had to guess, my answer also would be yes. Like, I'm thinking back to all the time. There seems to be this, additional structure that you have to go through, and man, that's got to create barriers to, the intensity of end of life care. Arguing for more intensity in the folks that got conservative. It seems like, for me, kind of open shut pre-reading this article. Of course they do.
That's what we thought too. That was our hypothesis going in. So we identified a group of people in the VA system who had guardians, and I can get back to why the VA later. And all of the patients in our sample had either moderately severe or severe dementia. And so we compared the end-of-life care received by patients with guardians to patients without guardians. And to our surprise, we found no significant difference between the groups.
What?
We looked at 6 outcomes. Three high-intensity treatments were more common in the guardian group, and 3 were more common in the control group.
Which three? Do you remember?
So the 6 were, I guess I can tell you. So ICU transfer, mechanical ventilation, and CPR were somewhat more common in the guardian group, but not in a statistically significant way. And then death in the hospital, repeated hospitalizations at the end of life, and placement of a feeding tube near the end of life were more common in the control group. Which was not what we expected.
And I'm looking at the numbers. They don't, even if they were statistically significant, they're not a very big difference between the groups. Like mechanical ventilation, 7% versus 6%.
Right.
Not huge differences.
Yeah, that's right. We thought that these types of high intensity treatments would be much, much more common among people with guardians, because that had been our experience. It was hard to imagine how somebody with a guardian would not get intubated if they developed respiratory distress. But in fact, that was not more likely among that group than the control group.
Okay, so let's digest this for a moment, and maybe we can do it in 2 different ways. The first is, there's something wrong with your study, because you found the wrong result.
That's gotta be it.
So is there any important limitations or caveats that would make you suspect that, maybe there is actually a difference and maybe we didn't detect it?
Sure. So, I think there are several important limitations. One of which, as with every study, you need to start with who's in the study population. So these are all veterans. They're all veterans with dementia. So they're mostly men, and they're mostly white.
And why did you choose veterans?
Because that was the only way we knew to identify people with guardians was using the VA electronic medical record. So the reason that this population has been difficult to study is that no one outside of a couple of states even keeps centralized registries of who's under guardianship. So it's been very hard to link the information about guardianship to a specific patient and to look at that patient's care. So there's certainly a limitation that these were all veterans. And then as we get to in the article, we had expected somewhat larger effect sizes. So it is possible that there is a smaller difference between the groups that we weren't powered to detect. But I think that your observation that even if these differences were to exist, they would be fairly small in magnitude is true.
Yeah, my preconceived notion was that there were going to be big differences. I don't really care if there was statistically significant small differences because, this is kind of destroying my preconceived notions.
And our preconceived notion, we should say, from working within the VA system. All right, let's take the other angle then. What if the paper's right? And surprising though these findings are, there really are no differences in the intensity of end-of-life care between older adults with dementia who have a guardian and those without a guardian. What are the explanations for the differences between what we expected based on our clinical experience and these findings?
Well, I think that one of several explanations, and I know this is something that Liz has thought about a lot. One possible explanation is that there wasn't a big difference because high intensity treatment was pretty common in the control group. So we found that a higher percentage of patients than we expected without guardians were getting these treatments. So there was less of an ability to detect a big difference because everybody was getting these treatments. And we make mention of this in the article, but others have devoted entire pieces to it recently, that certain types of high intensity care are becoming more common among patients with advanced dementia. And perhaps Liz has some thoughts about that, but I don't have a unifying explanation as to why that might be.
And do you think that the reason I had a preconceived notion, and probably a lot of providers do, is like recall bias, is that we think about conservators differently than family members. Maybe we expect them to be part of the healthcare team instead of part of the family team. I know I'm separating those two. They should be together, but maybe that's playing a role here. And that we're having conflict with somebody within the healthcare team, quote unquote, maybe cause me to remember those events more commonly?
Yeah, I certainly think that's part of it also. I think that we all have many years of medical training and get used to the idea that we're going to make a treatment recommendation to a family member and they may choose something different. When a stranger who doesn't know the person and is difficult to reach is doing something that we are distressed by, I think that is something we take with us and carry with us, and is deeply distressing in a way that a family member making the same decision might not be.
Mm-hmm. Right. And so we look for some explanation. And this is an easy explanation to land on. Oh, they don't know the person. They're not a family member. They're a professional conservator.
Conservator. Yeah.
That's great.
Yeah.
So we're looking for, and then Alvin Feinstein, who was a legend at Yale for years, predated you, wrote this wonderful piece called The Chagrin Factor. We remember our last bad experience. Oh, I remember what happened with that conservator, and that's going to shape my decision making going forward. So there's maybe these psychological biases are to explain some of this discrepancy between what we expect. And Liz, you got a comment?
Yeah, and I also was sort of thinking that, and this goes to sort of what I'd like to talk about later in terms of the way we think about autonomy and substituted judgment. But with families, there's sort of this inherent notion that they're going to generally do substituted judgment. They know the patient. And so, we are more okay with accepting that, I think. Whereas if it's a conservator, you're thinking, okay, this is part of the system. It's the healthcare system, and it's a little bit less personal. And so you're sort of like, when there's a decision that you don't think is consistent with what's clinically appropriate, you're like, oh, this is like the system, rather than like, okay, this is what the patient and the family may have wanted. So I'm wondering if that's maybe a bit of it as well.
And can you remind me of substitute judgment?
So substituted judgment. So I guess substituted judgment really focuses on the ethical principle of autonomy, which is one of 4 ethical principles, the others being beneficence or acting in the best interest of the patient, non-maleficence, doing no harm, and justice. And in the United States, we have this tremendous focus on autonomy for various reasons. And so substituted judgment is an attempt to pass that autonomy on to the family member or a surrogate if the patient no longer has the capacity to make decisions on their own. So substituted judgment basically is that surrogate makes decisions based on what they think the patient would have wanted if they were able to speak for themselves. So based on what they know about the patient's goals and values and prior life experiences, they're supposed to make that decision. Obviously, that can be very challenging sometimes.
What's the alternative?
So as I mentioned, there are 4 ethical principles, autonomy being one of them. And I think that my own sense is that these ethical principles should be equals. And so, it's not that autonomy is more important than beneficence and non-maleficence. They all should be considered equally. And so an alternative would be to think about these issues from perhaps a best interest standard, which is actually what's done in other countries. So, for example, in the United Kingdom, if a patient loses a capacity to make decisions, there's actually a Mental Capacity Act of 2005 that states that decisions should be made on a best interest standard. So you're sort of the doctor actually has the ability to make decisions based on what's clinically in the best interest of the patient. And now, of course, there's a lot of critiques about that, especially from Americans who think about that. They're like, well, how does that's very sort of paternalistic, in fact, for the doctor to say, this is what's in the patient's best clinical interest. But there are certain things that, we can make clinical judgments and they should also take into account the patient's best interest. The patient's goals and values and what the family wants and that sort of thing. But ultimately, you can think about, what's in the patient's best interest. That's one way. And there's
I remember, going back to an older JAGS article by Dan Sulmazy back in 2000, I think 7. They gave people hypothetical prompts of from a substituted judgment standpoint to a best interest standpoint. How do you want your family or providers to make decisions for yourself? And the majority wanted a combination of best interest standard versus and substituted judgment. And there are some people who just wanted substitute judgment and some people just wanted best interest. But it certainly wasn't everybody just wants substituted judgment and how they want their family or their loved ones or providers to make decisions for themselves.
Yeah, and I think that's also reflected in, how we experience it as well. And also the interviews that I've done with people is that actually having that autonomy without the guidance can be really stressful and very guilt. The families can have a lot of guilt around these decisions, and there's a huge burden of decision making. Sometimes you kind of want the doctors to sort of consider what's in the patient's best interest and guide the patient.
Yeah, I think this is particularly challenging when we think about dementia, because the maneuver we're asking people to do with substituted judgment for a person with dementia is to think about how the person, if they were able to have imagined themselves what it would be like to be in this state, what they would have wanted. And that's extraordinarily difficult. I mean, when we're thinking about someone who has a precipitous loss of capacity, is, in a car accident and then on life support, and where they want their heart shocked or something like that. I think that it's easier for us to imagine what we might want in that state, but to try to imagine what the long course is going to be like for dementia and what our preferences might be like at another time, and to try to communicate that to someone who's going to make decisions for us is really very difficult.
Yeah, there's been some pushback on the concept of advanced care planning, and we'll refer to other podcasts, the one we did with Sean Morrison particularly, where he quoted H.L. Mencken and said that for every problem, there is a solution that is clear, something, and wrong. And he included advanced care planning and advanced directives in that formulation. Liz, you wrote a very thoughtful critique and a commentary about Andrew's study. Do you want to tell us more about what your main thesis was in that commentary?
Yeah, so I thought what was most interesting about Andrew's study was this this lack of difference between guardians and known surrogates or, family members and that sort of thing. And I think that really highlights some of the things that we've already talked about, that, it's not that, and Andrew, you mentioned this, that the surprising finding was that actually there was more aggressive care in people with family members who are making decisions. And so that really points to how maybe there's just this culture of higher intensity care. And I also thought it was interesting that in your study, there was a lot of the people were in high intensity regions. So areas of the country where there was more high intensity care. And so, as a sociologist, I think about things on an institutional level and how institutional cultures and policies really influence this. And so I think the main takeaway that I got from this paper was that this just shows that a lot of what a lot of the way that we act isn't really based on how well we know the patient and how we're able to steer based on advanced care planning and advanced directives, but rather that the institutional culture plays a huge part in things. And so that's one aspect of it, but also that there are flaws in advanced care planning and advanced directives. And like Alex said, we can refer to the previous podcast with Sean Morrison about that, but also this concept of substituted judgment and this primacy of autonomy that we have in America, I think we need to rethink because, none of us, as doctors, we have a better sense of what goes on if someone is in the ICU, but somebody who's never had that experience just will have a really difficult time envisioning what that is. And so a person who's trying to write an advanced directive or think about, what their loved one said in their advanced directive and trying to extrapolate that into a family meeting that they're in right now, that's just going to be incredibly impossible to do, difficult to do. And so, maybe we should think about other ways that we can help facilitate decision-making that isn't necessarily just, what the patient, trying to think about autonomy, but also what's in the patient's best interest, what doesn't cause harm by overtreatment, and also the just distribution of resources and issues of social justice. And so, thinking about things like crisis communications, which is going to be helpful for both guardians and families and surrogates. How do we communicate between doctors and patients to help achieve the best results, thinking about institutional cultures and how we can put into place systems and policies that mitigate cultures of high intensity care and other things that, maybe supplement all the work that we've been doing in advanced care planning as well.
Mm-hmm. And are there examples from other countries that we can look to that models of care where and how much of that has to do with the system and the model of care, and how much of it has to do, as you say, with cultural differences between, what's normative in the U.S. and what might be normative in the U.K., for example?
Yeah, so it's actually quite interesting. So I've already talked about the U.K. and the Mental Capacity Act, but I think what's almost more interesting are the ways that we think about ethics differently in these countries. So in the US, when I interview doctors about, would you offer, treatments that might not work, or would you give treatments that probably wouldn't work, but it's what the patient wanted? Doctors in the US tend to say, oh, well, we need to make sure that we're, it would be unethical for me to override this patient's autonomy. And then when I talk to doctors in France and in the UK, they say, it would be absolutely unethical for me to admit a patient with advanced dementia to the ICU for high intensity treatments. That would create so much harm. That would not be in their best interest. And so I just think it's so interesting that we actually have completely different ways of thinking about what is ethical.
Yeah.
And so that's the question that I'm trying to get at. And it's a difficult question to get at. But yeah, I think it's beyond cultures and policies. It's how we think about what's right and wrong.
Well, I think that's the fascinating thing about Andrew's study is that it does argue that it's really not about the patient or the surrogate, like you were saying. It's about the system that we have in the U.S. that, patient preferences may not matter as much as we actually think in family preferences. It's what hospital you get admitted to, what's the culture of that hospital around end-of-life care, what are all the conflicts of interest as far as, what are they getting paid to do? So many factors. yeah, probably some of it is also like patient preferences and like potentially things like advanced care planning, but there are so many other factors that play a role in that.
Well, I will say a couple of, so I think that system level factors and cultural factors are probably hugely important. That many decisions are framed by them in an important way that we need to think more about. I will say that, so we have to remember in my study, these are patients with dementia. So whether or not there are broader cultural factors or this is a phenomenon for patients with dementia bears some further thought. I guess I'll also say that we had done another smaller study looking at a group of patients with guardians and their end-of-life care in the VA. And we did find that people who had a living will, some type of advance directive, even if generic, were less likely to get high-intensity care than people who didn't. So that may be because the court is looking for some evidence that the person might have wanted less than maximal care. I'm not sure why, but there does seem, at least for this population, to be some benefit to having an advance directive. And
I often feel like working with conservators, man, it makes such a big difference on what we say. It's like working with family members. If we say, this would be the standard of care, this is what we would do in this case and recommend in this case, and if I use the word standard of care, like we're all good. That's something that they can work with, and I often feel like they're looking for something that they can work with within the frame of what they can actually do. Like here in California, it depends on which county they're in, and it just reminds me, and your study reminds me, of the importance of communication, just like the importance of communication with family members, the importance of communication with conservators or guardians.
And I can think clinically of times when I've said to a conservator, hospice would be the standard of care for treatment for somebody with advanced dementia, like the person who you were assigned to care for.
Yeah. And it's so much harder for them to go against the standard of care.
Right.
I think that's a really important point. I think one of the challenges with the focus on autonomy is that sometimes people can equate that to like giving blanket, a menu of choices without making a recommendation. And so like stating that something's a standard of care, stating that this is like the very appropriate thing to do, or a recommendation is really important and can really help guide the conversation from the beginning.
Mm-hmm. My concern is what Andrew noted earlier on in our podcast, that there are rising rates of high-intensity interventions, many of them. Not tube feeds, right? I'm hopeful that tube feeds have been coming down at least.
The tube feeds have gone down a lot. It's interesting that that's occurred at the same time as other types of high-intensity treatment have gone up.
Right. And I don't think that we're returning to a place where it's, doctor knows best. But I do think that there is an argument to be made that because as doctors or nurse practitioners, clinicians who have seen many patients go through these experiences, who have the understanding of what the outcomes are of an intensive care unit visit for a person with dementia, that we have a responsibility, a professional responsibility to help guide these conversations, in terms of the information we provide, in terms of the recommendations that we make. I wanted to ask you another question we had a podcast with Barak Gaster, who created an advanced directive for people with dementia. I see both nodding, so you may have heard of this. And the idea there, as we talked about in that podcast, is that people who have dementia have a predictable course. There's sort of a signpost, if you will, of what typically happens to them. There will be certain decisions that need to be made along the way. For example, around feeding, as we were just talking about. At some point, it becomes difficult to swallow and coordinate those muscles effectively, and they're at risk for aspiration and aspiration pneumonia. And so here are some options, including hand feeding for persons when they reach that state. And that is particular to people with dementia. I'm interested in your thoughts about what you think of the dementia-specific advance directive.
I can go first. I think that it's helpful to have things like this, but I also continue to worry that there's still the problem of people not being able to anticipate their future self, especially with dementia. I mean, a lot of us, any of us, we think, oh, I wouldn't, many of us, I mean, there have been studies about this that, a lot of us would say we wouldn't want to be in a disabled state or wouldn't want to have that particular lifestyle. But then when we get there, or if we get there, we're okay with it, be it disability or with dementia where, you've forgotten, but you're happy. And so I think it's just so difficult for us to anticipate what our future state might be that, you can write those things down and yes, that'll probably be helpful. And I think that's actually more helpful for the family to help make them feel more comfortable about making these decisions. But in terms of like what actually that particular person might be feeling at that particular time when they've advanced to like moderate or advanced dementia, it might be completely different. And so I think that, I think it's still challenging. It's maybe a good step, but it's not perfect, I think.
So I think I have some specific concerns about dementia-specific directives. One of which is that they, by and large, ask people to give preferences about treatments when we know that it's really the outcomes of treatments that people care about. And as Liz is saying, those are really hard to imagine meaningfully ahead of time. In addition, in another recent qualitative study that we did here, we talked to people with early dementia and their caregivers about planning for the future and including advanced care planning. And most of them were really not prepared to do that. And there would be a lot of barriers to actually implementing such a directive. And I'm also, I think Liz is too, I think a lot about the selfhood problem with dementia, this idea that's sometimes called precedent autonomy, whether and to what extent your present self can make decisions for your future self. Mm-hmm. And I worry that people have such a difficult time imagining what their lives will be like if they develop dementia that it's hard for them to give preferences about specific treatments ahead of time. We don't need to go on this particular tangent. There's a long debate in the ethics literature about this. I think that having people predict in detail what they're going to want years into impaired capacity is really hard.
Yeah, I mean, I think this is one of the challenges with advanced care planning is that I think we try to apply it to everyone. I think there is a certain population of folks whose values are stay pretty consistent in either direction. It's like if I go to, like, I think Rebecca Shadori says, like, people change their mind. Like, if you ask me what I'm going to have for dinner, I may change my mind. However, like, if I'm a vegetarian, I'm probably not going to have a steak for dinner. Like, you can probably guess that pretty good as far as a future decision. But like for me, who's an omnivore, like, it really depends what my mood is when I finish work as far as what I'm going to pick up at the grocery store. So those values are going to change a lot versus, like, again, if I had some more deep-seated values about what I like and don't like for food. And I think it's the same thing when we think about advanced care planning. I think we just try to we try to make it so everybody gets it, but it may not be right for everybody. Wow. Everything's
Agreed.
silent after that.
I completely agree.
Well, Eric, I don't know about you, but I know what I'm having for dinner.
I was like, well, I feel like I would have a pretty good sense of what I would want, given how much I've been doing this work. But then, was it you, Alex, that did a study on doctors and how they actually have aggressive care that, that we all say that we wouldn't want? So.
Yeah, doctors tend to get more of all types of care, including hospice and including the intensive care unit.
And nurses too. Isn't there a follow-up study on nurses?
Right. Yeah.
So interaction with the healthcare system
about that one. And there are so many angles we could go here. Like, does video help Angelo Volande's work? Like Andrew was saying earlier, it's hard to imagine this whole issue of precedent autonomy. You can't imagine that future state. Well, here, rather than trying to describe it to you, I'm going to show it to you. Here's what it looks like, right? So much more visceral. Is that taking it a step too far? Is the images you show and the video you show going to bias somebody? Well, can't you make the same argument about language? There are so many subtleties and nuances that we don't have time to go into right now, but this is an incredibly complex area that nobody's going to solve. Liz?
Yeah, and I think that like a step in the right direction is trying to bring it more towards the person's life world or like their lived experience. And so, a lot of these advanced directives and forms talk about like, oh, I wouldn't want, antibiotics or pressors or mechanical ventilation, but, people might not know what that is. But when if they're sort of advanced directives that say, oh, I want to be able to like, eat ice cream in front of the television and that's fine with me versus like running a marathon, I think that's getting closer to it because it's sort of bringing it more towards like their lived experiences. But there's still, challenges with that as well.
No, I feel like that's our current, the Vital Talk training around how to have goals of care conversations. It's all about, figuring out what's important to them, what they're worried about in their current situation or a future state, what they're hoping for, and then making recommendations. And it certainly would be nice to have advanced directives that also are aligned with kind of how we currently think about goals of care conversations.
Mm-hmm. But again, particularly challenging in dementia, which has such a long course that you will inevitably be making those decisions well in advance of the time at which you'll be experiencing those conditions.
Yeah.
Yeah, I think one of the pieces I think has to be, and maybe some of us do this without an organized framework, but thinking about how to train even family member surrogates to know what they're supposed to be doing. I think I certainly myself have invoked the idea of substituted judgment in a family meeting, and what we're actually asking the family member to do is really hard, and just expecting them on the fly to be able to understand the question like, what would your loved one want? That's a lot in a difficult moment with no preparation or explanation of what that means.
I'm gonna just mention Prepare for Your Care as one way to do that. I'm just gonna give a quick plug to Rebecca Sidori's website that I really encourage our listeners to go to and check it out as one way to prepare family members. But my last question though, I want to go back to Andrew around the issues of conservators and guardians. After you got these results, is there like one thing that you've done differently based on this results from a clinical perspective? Or was this just an interesting finding?
I know that this is something that I've done differently, but I think my blood pressure rises a little bit less when I see a patient with a conservator or guardian. I don't necessarily expect things to go a certain way. And in doing that, I've noticed more often that things are happening where patients aren't getting high intensity care, or I am able to reach the conservator. So I think this bias that things are inevitably going to go down the path of high intensity care, I've started to question that.
Mm-hmm. And Liz, my last question is for you. There's this saying, geography is destiny, but maybe if you had like a t-shirt saying like, what is it you study? It's more like culture is destiny. I wonder but culture change is hard. Like, how do we change norms around care? How are there places where this has happened? What are the forces that push norms in one direction or another?
I mean, that's the $1 million question that I think many of us are trying to figure out. I think that there's like norms within the hospital, which I think we can change through, leadership actually, I think has a big influence on culture change, the people who are in it, and the structures of support that are around, the ethics committees, how supportive things like risk management are, and how easy it is to do certain things. So, are there, palliative care teams that can actually be there, or is there a culture where, you say palliative care and people are like, what, that's not right. So I think there are a lot of things that can be done within the institution to try to change this culture. And I also think that we need to think about this on a more societal level, which of course requires cooperation of people beyond doctors and researchers. So thinking about how society thinks about end of life care, whether or not this is a welcomed conversation in the policy realm, whether or not even things like whether or not Hollywood has like realistic depictions of CPR and that sort of thing. So I think that there's many ways that we can approach this. Of course, there's also things like death over dinner. What is it? Death over dinner in death cafes and those sort of things. And there's a lot of efforts out there to try to change that culture.
Yeah, and I think that the one thing that gives me optimism is that we know we can change things because, like we mentioned, feeding tube insertion in individuals with dementia, the rates of that have gone down significantly in the last 10 to 15 years. So, I think there are better things ahead.
Yeah, and I think actually
Alex got it.
I caught that.
Well, I was about to say that I think that the feeding tubes and choosing wisely campaigns have been really helpful with that. So really good education around feeding tubes has been helpful.
Well, I want to thank both of you for joining us today. But before we end, we got a little bit more better things up ahead.
Here's hoping all the days ahead won't be as bitter as the ones behind you. Be an optimist instead, and somehow happiness will find you. Forget what happened yesterday. I know better things are on their way. It's really good to see you rocking out and having fun, living like you've just begun. Except tomorrow and what it brings. I hope tomorrow you'll find better things. I hope tomorrow you'll find better things.
Liz, Andrew, big thank you for joining us for this podcast. And thanks for really everything that you do. Really encourage our readers to check out their JAGS articles. We'll have a link to that in our show notes. A big thank you to Archstone Foundation for your continued support and all of our readers. Again, big thank you for supporting our Jerry Pal podcast. If you have a moment, please rate us on your favorite podcasting app.
And look out for a opportunity to win a Jerry Pal face mask to be announced on a podcast in the next few weeks.
Thanks, everybody. Good night.